Hi everyone, and welcome to our module on uterine cancer. Let's start by talking about leiomyomas, which are also known as uterine fibroids. These are benign tumors of myometrial smooth muscle that occur in the uterus. They develop in premenopausal women, and the reason for this is because their growth is stimulated by estrogen, and estrogen levels are higher in women before they've undergone menopause. Usually fibroids resolve at menopause because that's when estrogen levels fall, and that stops the growth of the tumor, and they often shrink. Women often have more than one fibroid, and there are multiple locations within the uterus where they can occur. So if you look at this picture on the slide here, it shows many of the different types of uterine fibroids. So a submucosal fibroid is embedded into the wall but extends into the cavity of the uterus. Some fibroids have a stalk, those are called pedunculated. Fibroids can also occur on the outer surface of the uterus, these are called subserosal fibroids. They can also be in the wall, these are intramural fibroids, and sometimes a pedunculated fibroid can extend through the cervix like shown here. And we'll talk in a second about the symptoms of fibroids, but one of the symptoms is abnormal uterine bleeding. And you should know that the submucosal fibroids, this type right here, is the type that has the highest risk of abnormal uterine bleeding. So that's a nice segue into the clinical features of leiomyomas. So many of these are asymptomatic, and women are unaware they have them until they have a pelvic exam or an ultrasound for some other reason. If fibroids get very large, they can cause what's known as bulk symptoms. These are symptoms like pelvic pain and bloating. Large fibroids can also cause constipation or urinary symptoms like frequency or retention. As I mentioned on the last slide, fibroids can cause abnormal uterine bleeding, and the submucosal type is most likely to do this. They can also cause painful menses, which is dysmenorrhea, and painful intercourse, which is dyspareunia. They're often detected as a pelvic mass during a pelvic exam. The uterine shape can be irregular or enlarged because of fibroids. And as I showed you on the last slide, rarely they can prolapse through the cervical os, and you can see them on a cervical examination. In terms of diagnosis, the first-line test for leiomyoma is usually a pelvic ultrasound. This is a picture of what a uterine fibroid looks like by ultrasound shown on the screen here. An alternative option is hysteroscopy. This involves inserting a scope into the uterus, and you can directly visualize the walls of the endometrial cavity. This will allow you to diagnose fibroids that extend into the uterine cavity, but as you can imagine, you can miss those subserosal fibroids we showed 2 slides ago because they're on the outer surface of the uterus. Another option for diagnosis is saline infusion sonography, also known as sonohysterography. This is also an ultrasound technique, but during a transvaginal ultrasound you inject saline into the uterine cavity, and this gives you better visualization, and it detects small fibroids better than transvaginal ultrasound alone. It's high yield to know that uterine fibroids are a common cause of size-date discrepancy in women who are pregnant. I talk about size-date discrepancy in videos in the obstetrics section, but what you want to know is that many women have fibroids that are undetected prior to pregnancy. And what this means is when you examine the uterus during pregnancy, it will be larger than expected. This is called a size-date discrepancy. But the reason it's larger than expected is not because of any problem with the baby or the pregnancy, it's because the woman has fibroids. In addition to the fact that the fibroids can be undetected before pregnancy, they can also rapidly grow during pregnancy because of the high estrogen levels. So on exam of a pregnant woman who has fibroids, the uterus will be larger than normal, and it can also potentially be irregular. In most cases, fibroids do not adversely affect pregnancy. However, if they are large and there are multiple fibroids, sometimes this can lead to adverse outcomes. Some of the things that can happen is there can be fetal loss, potentially placental abruption, or preterm birth or malpresentation. And then usually women who have fibroids identified during pregnancy find that they shrink postpartum, and that's because the estrogen levels return to normal and they aren't as high as during pregnancy. Okay, let's talk about the treatment of leiomyoma. There are a couple of options for medical therapy that can reduce the size of fibroids and the amount of bleeding from fibroids. The idea behind most of these drugs is that progestins oppose the effects of estrogen. So if you give a woman a drug with progestins, that will often lead to shrinkage of the size of fibroids. So for women who desire contraception in addition to treatment for their fibroids, combined oral contraceptives are a popular option. They contain progestins and they can cause the fibroids to shrink. You can also use progestin-only contraceptives or the LNG IUD, which contains a progestin. And then in some cases GnRH agonists are used. These drugs decrease LH and FSH release from the pituitary, and that will decrease ovarian stimulation and lower estrogen levels, which can help to shrink the fibroids. There are also many non-medical options for fibroids, and which option you recommend depends a lot on whether the woman desires fertility and wants to become pregnant in the future. For women who do not desire fertility, hysterectomy can be curative for fibroids. These women can also have a myomectomy, which is a procedure where you just remove the fibroid. And then another option is uterine artery embolization, which we'll talk about in a second. For women who desire fertility, the option that's almost always recommended is myomectomy. This is removal of just the fibroid. This can be done under guidance by a hysteroscope. This is called hysteroscopic myomectomy, or it can be done as an open abdominal procedure. And you should know that there is a risk with any myomectomy that the procedure can become complicated and ultimately a hysterectomy can be required. So although a myomectomy is intended to retain the uterus, women have to be prepared that in some cases hysterectomy is still necessary. So uterine artery embolization is a minimally invasive option for treatment of fibroids. It involves accessing the uterine artery with a catheter and then injecting an agent which thromboses the blood supply to the fibroid so that it will shrink. And this can improve bleeding and bulk symptoms in women who have fibroids. It's used only in premenopausal women, and it's high yield to know this. The reason for this is that most fibroids shrink after menopause, so usually women don't need a uterine artery embolization after menopause. In addition, women who have enlarging or symptomatic fibroids after menopause should have surgery because these are older women and it may not be a benign fibroid causing their symptoms, but may actually be some type of malignant tumor. And then uterine artery embolization is generally not used in women who desire fertility. The reason for this is that once you thrombose the blood supply to a portion of the uterus, often it will have trouble supporting pregnancy after that. There are reports of women who became pregnant following a uterine artery embolization, so it is possible, but in general this procedure isn't recommended for women who want to retain the blood supply to their uterus so that it can support a pregnancy in the future. Let me briefly mention in this one slide uterine sarcoma. This is a very rare but malignant smooth muscle tumor of the uterus. It's like the malignant version of a fibroid. This usually occurs in postmenopausal women, usually as a single large mass. It can cause bulk symptoms from the size of the mass, and it may also cause postmenopausal bleeding. And we'll talk in a minute about the drug tamoxifen, but there's an increased risk of uterine sarcoma in women who take tamoxifen therapy. And so many of the clinical features of uterine sarcoma are similar to fibroids, but sarcomas occur in postmenopausal women. And that's why in a woman who is postmenopause, who has symptoms that sound like a fibroid, usually surgery is done. And that's because there's a higher chance that that woman may not have a benign fibroid, but may instead have a malignant uterine sarcoma. Okay, so for the rest of this video, we're going to talk about endometrial growths and endometrial malignancies. And in order to understand these things, we have to first talk about estrogens and their effect on the endometrium. So estrogen exposure drives endometrial growth, but that growth is opposed by the effects of the hormone progesterone. So I talk about the menstrual cycle in detail in another video, but if you want to think about the menstrual cycle very simplistically, we can make a graph and put time along the x-axis and call this point right here the middle of the menstrual cycle, and that's when ovulation occurs. Well, during the first half of the menstrual cycle, what happens is that estrogen levels go up and then they sort of slowly come down. In the second half of the menstrual cycle, what happens is progesterone levels go up and then come down. So this estrogen produced in the first half of the menstrual cycle is opposed by progesterone in the second half of the menstrual cycle. And then, of course, at the end of the menstrual cycle, you have menses and the endometrial lining is shed. So we call this release of estrogen that occurs as part of the normal menstrual cycle opposed estrogen release, because the estrogen is released by the ovaries, but then later opposed by progesterone in the second half of the menstrual cycle. But if you have a source of estrogen outside the menstrual cycle, we call this unopposed estrogen because it's not occurring as part of the menstrual cycle and it's not opposed by progesterone in the second half of the menstrual cycle. And so if you have an excessive amount of unopposed estrogen, that will drive growth of the endometrium, and that can drive abnormal growth. And that's how things occur like uterine polyps and endometrial hyperplasia and also endometrial carcinoma. So what are some potential sources of unopposed estrogens? Well, a big one is obesity. That's because adipose tissue converts androgens into estrogens. So women with obesity essentially are constantly producing estrogens from the fatty tissue in their body. And this leads to high levels of unopposed estrogens, and that increases the risk of endometrial growth and endometrial malignancies. Tamoxifen is a drug used to prevent breast cancer. We'll talk about this in a second, but this is associated with endometrial growth and endometrial malignancy. And then women who do not ovulate have unopposed estrogen. That's because ovulation is required for that spike in progesterone that occurs in the second half of the menstrual cycle. So when women do not ovulate, the ovaries will produce estrogen but not progesterone, and that leads to unopposed estrogen. So I talk about anovulation in other videos, but it's common in women who have polycystic ovarian syndrome. It also occurs as women approach menopause. They have anovulatory cycles, and all of these things produce estrogen but not progesterone, and that leads to the endometrium being exposed to unopposed estrogen. And then it's rare, but there are estrogen secreting tumors. And lastly, women who take hormone replacement therapy with an estrogen component only and not a progesterone component will have endometrial growth and unopposed estrogen. And I talk about hormone replacement in detail in other videos. And so if you understand all these things I've listed on this slide, then it's very easy to understand the risk factors for endometrial polyps and endometrial hyperplasia and endometrial cancer, because all of those growths of the endometrium are related to unopposed estrogen sources like the ones listed on this slide. It's also important to understand the different sources of estrogen in women when they are pre versus post menopause. So pre-menopause, most estrogen in women comes from the ovaries, and it comes as part of the menstrual cycle where it's opposed by progesterone. And this is what we talked about earlier. This is shown in this graph at the bottom of the screen. Before menopause, estrogen and progesterone levels go up and down like this with each menstrual cycle, but the estrogen is generally opposed by progesterone. After menopause, however, estrogen levels decline and eventually the ovaries stop releasing estrogen. In this setting, most of the estrogen in women comes from adipose tissue, and when it comes from adipose tissue, it's going to be unopposed by progesterone. So women who are postmenopausal are at increased risk for endometrial malignancy because they have unopposed estrogen coming from their adipose tissue. In particular, postmenopausal women who are obese or who have lots of adipose tissue are going to be in a higher risk category because they have lots of circulating unopposed estrogens. Let's talk about tamoxifen, which is a selective estrogen receptor modulator, or a SERM. This drug is used to prevent breast cancer because it's an antagonist of the breast estrogen receptor. So it's used in women who have estrogen receptor positive breast cancer. But even though it's an antagonist to estrogen receptors in breast tissue, it's an agonist to estrogen receptors in other tissue, like in the bones and in the uterus. In particular, it's a partial agonist to estrogen receptors in the endometrium, and therefore when women take this drug to prevent breast cancer, they can develop endometrial proliferation. Polyp formation is very common, we'll talk about this in a minute, but up to 36% of women on tamoxifen develop endometrial polyps, and hyperplasia can also occur. And because the drug drives this growth of the endometrium, it's associated with endometrial cancer and also endometrial sarcoma, which we talked about earlier. Okay, so now that we understand what unopposed estrogen is, let's talk about the consequences of unopposed estrogen in the uterus, and we'll start by discussing endometrial polyps. Endometrial polyps are hyperplastic growth of glands and stroma, and usually they are benign about 95% of the time. There's a small risk of malignancy from an endometrial polyp, especially when they occur in women who are postmenopause. Polyps project from the endometrium. They're described as an exophytic mass. The word exophytic means growing outward from a surface. This is a picture on the screen here of what they can look like. In many cases, endometrial polyps are asymptomatic, but they can sometimes cause painless uterine bleeding. The development of endometrial polyps is associated with unopposed estrogen, and all those sources of unopposed estrogen we talked about earlier can be risk factors for endometrial polyps. They can be diagnosed by transvaginal ultrasound or by hysteroscopy. On hysteroscopy, a scope is inserted into the uterus and you can directly visualize the polyps, like what's shown in this example on the slide here. In addition to visualizing the polyps with hysteroscopy, you can also remove them as part of a hysteroscopy procedure, and this can often be done in the office. In premenopausal women, the main indications to remove a polyp are if they are bleeding or if the woman has a high risk for development of endometrial cancer, for example, if the woman has polycystic ovarian syndrome or some other source of unopposed estrogen. And in postmenopausal women, polypectomy or removal of the polyp is done for all women because the chance of cancer is higher in this group. Okay, so endometrial polyps are one potential consequence of unopposed estrogen, but another and more serious potential consequence is endometrial hyperplasia. This is often a precursor of endometrial carcinoma. Endometrial hyperplasia is stimulation of endometrial growth by unopposed estrogen in the absence of progesterone stimulation and withdrawal, just like we talked about earlier. As opposed to a focal, usually benign growth, which is what you see in endometrial polyps, in endometrial hyperplasia, there's usually more generalized growth, like what's shown on the screen here, and the risk of development of cancer is much higher. And endometrial hyperplasia often occurs in peri- or postmenopausal women. That's because menstruation has slowed or stopped, so these women are not ovulating. Therefore, there's no progesterone from the ovary to oppose estrogen. And so as these women enter menopause, any estrogen source, whether that's the ovaries or adipose tissue, can lead to hyperplasia because the estrogen is no longer opposed by progesterone. The main clinical feature of endometrial hyperplasia is abnormal uterine bleeding. I talk about abnormal uterine bleeding in another video, but in women who are postmenopausal, any uterine bleeding is abnormal and should raise concern for endometrial hyperplasia. In women who are still menstruating, abnormal uterine bleeding is menstrual bleeding outside the woman's usual menstrual pattern. So in any woman with abnormal uterine bleeding, you have to consider endometrial hyperplasia. You also have to be aware that the presentation of endometrial hyperplasia with abnormal uterine bleeding is the same presentation as for endometrial carcinoma. And the risk factors for endometrial hyperplasia are also the same as those for endometrial carcinoma. So you can't tell endometrial hyperplasia from carcinoma clinically unless you do an endometrial biopsy. And so this must be done in all women who have abnormal uterine bleeding and risk factors for endometrial hyperplasia, like sources of unopposed estrogen. And when you do a biopsy, the results will tell you whether the woman has endometrial hyperplasia, which is a precursor to carcinoma, or whether the woman has endometrial carcinoma. You should also know that sometimes a pap smear identifies evidence of endometrial hyperplasia. It may show endometrial cells. These are reported in the pap smear report as either atypical glandular cells or endometrial cells. And when this finding occurs in a pap smear, this is usually followed by an endometrial biopsy in women who are at high risk for carcinoma. And I talk about pap smears and the findings of pap smears in more detail in the video on cervical cancer. Okay, so now let's imagine a woman has abnormal uterine bleeding. She has an endometrial biopsy that identifies endometrial hyperplasia. Let's talk about what to do in terms of treatment. First of all, you want to treat the source of unopposed estrogen if possible. So for example, if the woman had polycystic ovarian syndrome and anovulation, you would try to resolve the anovulation if possible. For women who are obese, if they can lose weight, that will lower the estrogen amount in the body and lower the amount of estrogen exposure to the endometrium. Beyond treating the source of estrogen, if the woman has a low-risk form of endometrial hyperplasia, and I'll talk about the different forms in a second, then those women are often treated with progestins, often with the levonorgestrel IUD. This is an intrauterine device that contains a progestin. And the idea here is that progestins oppose estrogen effects. They can reverse hyperplasia and improve bleeding from endometrial hyperplasia as well. But progestins are only for women with low-risk forms of hyperplasia. If women have a high-risk form, and I'll talk about this in a second, then those women have a hysterectomy because the risk of progression to endometrial carcinoma is very high. So now let's talk about interpretation of endometrial biopsy results. So there are a number of different results you can get back from an endometrial biopsy. One of the most benign results is a proliferative endometrium. This is not a form of endometrial hyperplasia. It means that the endometrial appearance is similar to the proliferative phase of the menstrual cycle. Since this is not a form of endometrial hyperplasia and not a form of endometrial cancer, the treatment when you get this biopsy result is based on the patient's symptoms. You provide whatever treatment you normally would for the woman's bleeding, but no special treatment because of the finding of proliferative endometrium. The one caveat is if the woman has risk factors for unopposed estrogen like obesity or anovulation, you may provide counseling about decreasing those risk factors because a woman who has proliferative endometrium now could develop endometrial hyperplasia down the road. A more serious finding on an endometrial biopsy is endometrial hyperplasia without atypia. This means there is endometrial hyperplasia present, but because there's no atypia, it means the cancer risk is low. So if the woman is premenopausal, she can simply be observed, or you can treat her with progestins. In women who are postmenopausal, this is a lower risk finding, so usually they can be treated with progestins and they don't need to have a hysterectomy. On the other hand, if the biopsy shows endometrial hyperplasia with atypia, then this represents an early malignant neoplasm. This is managed with progestins in women who have not yet completed childbearing. It's treated with hysterectomy in women in whom childbearing is no longer desired. But the main point here is that when there is atypia present, it means the woman has developed a malignant neoplasm. Okay, and so besides a proliferative endometrium or endometrial hyperplasia, an endometrial biopsy in a woman with abnormal uterine bleeding may show evidence of endometrial carcinoma. Endometrial carcinoma is the most common gynecologic cancer, and it's most common in women who are postmenopausal. The average age at the time of diagnosis is about 60 years, and the reason it occurs in women after menopause is because they are anovulatory. When women don't ovulate, they don't produce progesterone. This means that all the estrogen in their body is unopposed, and so this increases the risk of endometrial hyperplasia and endometrial carcinoma. And so the classic presentation is abnormal uterine bleeding. In a woman who is still having menstrual periods, this will present as bleeding that is different from the woman's usual menstrual pattern. In a woman who is postmenopausal and has stopped menstruating, this will simply present as uterine bleeding when she hasn't had any uterine bleeding for some time because of menopause. There are two major subtypes of endometrial carcinoma. They are distinguished from one another based on the appearance of the biopsy. Type 1 is the endometrioid subtype. This is the type that develops from estrogen-dependent hyperplasia in women who have unopposed estrogen sources. It's called the endometrioid subtype because the tumor under the microscope resembles endometrium. The other subtype, which is less common, is the serous subtype or type 2. This form of endometrial carcinoma is estrogen independent. It arises from an atrophied endometrium in women after menopause. And one thing that's sort of high yield to know about this subtype of endometrial carcinoma is that it has a very strong association with p53 gene mutations. The p53 gene is a tumor suppressor gene, and it's mutated in 90% of endometrial carcinomas of the serous subtype. And in general, this subtype has a poor prognosis. It's the more aggressive subtype compared to the estrogen-dependent endometrioid subtype. The diagnosis of endometrial carcinoma, as I said before, is made through endometrial biopsy, and the standard treatment is a total abdominal hysterectomy. Radiation is used for locally invasive disease, and chemotherapy plus radiation is used for metastatic disease. Now, although a total hysterectomy is the standard treatment, you should know that in a minority of cases, progestins can sometimes be used in women who have low-risk forms of endometrial carcinoma. This is usually reserved for cases of young nulliparous patients who want to have children, who have a low-risk form based on their biopsy. In some cases, you can induce remission by administering progestins, but as I said, this is done in a small number of cases. The standard treatment is a total hysterectomy. And we'll finish this video with one slide on HNPCC, which is the hereditary non-polyposis colorectal cancer syndrome, also known as the Lynch syndrome. Patients with this condition have a germline mutation in DNA mismatch repair genes, and this leads to colon cancer. This is a colon cancer genetic syndrome, and I talk about it in detail in videos in the GI section. But I'm mentioning it here because women with HNPCC also have an increased risk of endometrial cancer. Endometrial carcinoma is the most common non-colon malignancy in women with HNPCC. And because the risk of endometrial cancer is so high, these women often get regular endometrial sampling with endometrial biopsy. The guidelines vary, but usually biopsies begin at age 30 to 35 or 10 years before the earliest family member's cancer diagnosis. And that concludes our video on uterine cancer.